Good afternoon, everybody. Ladies and gentlemen of the jury, good afternoon. Dr. White, good afternoon, sir. Do you acknowledge, sir, you're still under oath and still sworn to tell the truth?
Yes, sir, I do.
Thank you. This would be a resumption of cross-examination by Mr. Walgren.
Thank you.
Thank you.
May I have just one moment, Your Honor?
You may.
I have a quotation, Your Honor, from the textbook Intravenous Anesthesia by Paul White. May this be marked People's 236 for identification?
Marked.
Dr. White, can you see that from where you're seated?
Yes, I can.
And do you recognize that as an accurate quotation from your article, Propofol, in the textbook of Intravenous Anesthesia?
I believe it is, although, again, it's out of context, so
Okay.
if you want to show me, that's be appreciated.
May I approach the witness, Your Honor?
Yes, please.
Dr. White, showing you page 120 of your article, beginning with the word because. Could you read that out loud, please?
Yeah, I just wanted to see the whole context.
Take a moment.
Thank you.
Sure.
Can I read it from the start of the paragraph?
No, I want to, first I want you to just reference this and tell me if it's accurate. Is that an accurate quotation?
Yes, it's taken from the middle of a paragraph, much larger paragraph, describing the use of propofol infusion.
Okay. Do you need to read the whole paragraph to put into context? Is that what you're asking?
Well, I just think it's useful to put things taken out of context in the context in
Okay.
which they were written. So,
Why don't you read out loud from the, where do you want to begin reading? From the word propofol
I guess.
to the last word surgeons?
Yeah, propofol sedation has been used to provide satisfactory conditions for upper gastrointestinal endoscopic procedures. Use of an infusion of propofol, 72 mics per kilogram per minute, produced cooperative patient with complete amnesia for the procedure, while providing for awakening and orientation in approximately 4 to 6 minutes after discontinuing the infusion. Patterson and colleagues reported faster recovery and reduced hangover effects following propofol compared with midazolam when these drugs were administered.
A little slow and a tad louder, please.
I'm sorry.
That's all right.
I have a cold, so I'm...
Okay, well, just sit back if you would. Are you up to the area, or you want Dr. White to repeat anything, Mrs. Theodore?
We can start from hangover, Your Honor.
And reduced hangover effects following propofol compared with midazolam when these drugs were administered for upper GI endoscopic procedures, period. However, the shorter duration of hypnosis following the bolus dose of propofol resulted in more recall at the end of the endoscopic procedure. The use of one or more supplemental doses of propofol would have extended the period of unconsciousness and reduced recall. Similar results were obtained in a comparison of propofol and midazolam for outpatient bronchoscopy. Because of the potential for profound cardiovascular and respiratory depression, propofol should always be administered by personnel trained in the administration of general anesthesia and not by gastroenterologists, radiologists, or surgeons.
Thank you, Doctor. So the quotation on the screen, that is an accurate quotation, just read the paragraph preceding it?
Yes, it was an accurate quotation from a book that I published in 1996 and does not represent current practices.
Okay, and so do you no longer agree with this statement?
No, many anesthesiologists, radiologists, pulmonologists, and even surgeons administer propofol in intensive care for sleep and for procedural sedation in endoscopic suites. Oral surgeons administer it for oral surgical procedures.
Okay, so this was kind of the accepted view when your book was published, but it's evolved over the years with wider use of propofol. Is that accurate?
Yes, correct. Textbooks, as you know, are a little bit dated when they're published because it takes a couple years to get all the manuscripts. So I would say this reflects kind of the thinking in the early 1990s.
And then your view now would be, you would still agree that it has propofol has a potential for profound cardiovascular and respiratory depression?
Yes, sir.
But in the appropriate setting, it could be administered by non-anesthesiologists, correct?
Correct.
And in fact, the American Society of Anesthesiologists has specifically addressed this issue and presented guidelines for non-anesthesiologists when using these types of agents, correct?
Yes, I think there are clear guidelines for providing conscious sedation, if you will.
I have two separate quotations, Your Honor. First one may be marked People's 237 for identification,
Marked.
and that's from the practice guidelines for sedation and analgesia by non-anesthesiologists. And an additional quotation from the same document, may that be marked People's 238 for identification?
Yes. Please show them to Mr. Flanagan, who's reviewing them.
Dr. White, do you see People's 237 on the ELMO?
Yes, I do.
Okay. And do you know that to be an accurate statement taken from the guidelines we just referenced? Or would you like to see the guidelines?
I can't be certain without looking at the guidelines, so if you don't mind, I would.
And I do have in my hand a copy of the practice guidelines for sedation and analgesia by non-anesthesiologists published in 2002. May I approach the witness, Your Honor?
You may.
Looking at People's 237, Dr. White, and looking at page 1011 on the guidelines that I've underlined in red, do you recognize that as an accurate quotation taken from the guidelines?
Yes, it is accurate.
And it states, even if moderate sedation is intended, patients receiving propofol by any route should receive care consistent with that required for deep sedation, correct?
Yeah, any route. Yes, that's what it says. These guidelines are from 2002. I think they've been updated. And my understanding is actually that the guidelines are that you rescue from one deeper level of sedation. That's my understanding of the current guidelines, but I could be mistaken.
And looking at People's 238 for identification, Can you see that, Dr. White?
Yes, I'm familiar with that quote.
Do you need to see the guidelines, or
No, I know that quote.
could you read that out loud, please?
Because it is not always possible to predict how a specific patient will respond to sedative and analgesic medications, practitioners intending to produce a given level of sedation should be able to rescue patients whose level of sedation becomes deeper than initially intended.
Would you agree that when administering propofol in a home setting without the personnel, without the equipment available in a medical type setting, that the best course of action would be to be prepared for moderate or deep sedation?
Yes, sir.
And if the concern is for the patient's well-being and the patient's life, if propofol is being administered in such a bedroom setting without all the available equipment, what should be done is preparation for deep sedation.
Well, I think you said moderate or deep sedation, and I agree with that. If your intended goal is minimal sedation, that is anxiolysis, and minimal, if any, sedation, then it would be moderate sedation, not deep sedation.
And if an infusion line, a drip is running, when you characterize that as moderate sedation at least?
Typically, when an infusion is used, it is, in fact, moderate sedation or conscious sedation, correct?
And so if an infusion is used, it would be typically moderate sedation, in which case they should receive the care consistent with that required for deep sedation, correct?
Yes, they should be capable of rescuing a patient who drifts into deep sedation. I think that's what the guidelines suggest.
You know, I have a picture of the, I have a one-page document taken from the practice guidelines documenting the recommendations as to standard of care for moderate and deep sedation. May this be marked Peoples 239 for identification?
Yes, please show it to Mr. Flanagan. Who's reviewing it?
Dr. White, you're familiar with these guidelines that I just referenced, correct?
Yes, I'm familiar in general terms. I couldn't recite specific points. It's quite a lengthy publication.
And it notes that these recommendations apply to both moderate and deep sedation, correct, for non-anesthesiologists?
Yes, sir.
And just going through kind of in summary fashion, they first discuss the need to have pre-procedure evaluation where you get relevant history, physical examination, laboratory testing, and things of that nature.
Yes.
It goes through patient counseling and pre-procedure fasting on number 2 and 3. Is that right?
That's correct.
The section on monitoring recommends pulse oximetry, exhaled carbon dioxide monitoring, blood pressure, heart rate at 5-minute intervals, and electrocardiograph for patients with significant cardiovascular disease, correct?
Yes.
And then notes for deep sedation, exhaled CO2 monitoring considered for all patients, and electrocardiograph for all patients, correct?
Yes.
If you were administering propofol in a home setting, is that the standard of care you would utilize as far as monitoring?
Well, as I said earlier, I wouldn't administer propofol in a home environment, but if I was using an infusion of propofol, absolutely.
Going down, personnel says designated individual other than the practitioner performing the procedure present to monitor the patient throughout the procedure and this person may assist with minor interruptible tasks. For deep sedation, the monitoring individual may not assist with other tasks. Would you agree with that if you're running an infusion in a home setting?
Yeah, that's correct, but you'll note they refer to a procedure going on. That means someone is performing either a diagnostic or therapeutic procedure, and so they wouldn't be appropriate to be monitoring the patient.
So, but do you think if propofol was given in a home setting for not for a procedure, but to put someone to sleep, are you saying you don't think it's a good idea to have those precautions in place?
I don't think I said that, sir.
Okay, you would agree that it is a good idea to have those precautions?
What I'm just pointing out is they're referring to someone doing a procedure and suggesting there needs to be a second person there to monitor the use of an infusion for sedation. And I think that is a good practice, and I endorse that. But what I'm suggesting is it seems like you're making the analogy that that's the same as someone providing propofol for a different purpose.
Well, I just want your opinion. Do you think if someone's providing propofol for sleep in a home setting, that there should be, for example, another person present in addition to the medical doctor?
I think they certainly need appropriate monitoring if they're using an infusion. It's not a practice that I'm familiar with, nor have I heard of it being described in the past, so I can't really make a recommendation as to the need for a second person, assuming that the physician that is providing the sedation is qualified and is devoting their attention to the patient.
So you'd at least be assuming that the doctor administering the propofol, at least that one person is at least present and monitoring the patient, correct?
While the propofol is being administered, absolutely.
And then it goes through recommended training in pharmacology, is that right?
Yes, sir.
And then going to the right column, it discusses both the need for basic and advanced cardiac life support skills.
Yes.
Runs through the various emergency equipment, including suction, drugs, a defibrillator for deep sedation, oxygen, choice of agents, induction agents, and goes through all the recommended various agents that would be appropriate in that type of environment where moderate or deep sedation was taking place, correct?
Correct.
And recovery, number 14, they identify the need to observe observation until patients no longer at risk for cardiorespiratory depression. Is that right?
Correct.
Now, do you think these guidelines are appropriate if someone's administering propofol in a bedroom of a private residence with no other staff present?
I think in general these describe very excellent recommendations for administering a propofol infusion in any environment.
What about administering benzodiazepines and a propofol bolus? Do you feel that these recommendations are appropriate?
Well, as I alluded to earlier, certainly benzodiazepines parenterally are administered in home environments by physicians and hospice caregivers and others without all these monitoring procedures.
I'm asking your opinion, Dr. White, if you think if someone's administering benzodiazepines and let's just say a bolus dose of 25 milligrams of propofol in a home setting with none of the, do you feel that the guidelines here would be appropriate if your concern was to put the patient first?
Well, I certainly would agree with putting the patient first in all situations and not putting them at any risk. What I was alluding to was that while these are the standard of practice, which is the gold standard, the highest possible standard in practice, I'm suggesting that certain situations in the home where these drugs are administered may not have all the specific monitoring guidelines that are mentioned here. Not that it would be a bad idea to have those. Certainly, again, you wouldn't want to compromise patient care.
So it'd be a good idea to have these recommendations in place if you're administering even bolus doses of propofol in a bedroom in a home setting.
In an ideal situation, absolutely right.
Your Honor, may I inquire if we have the defense exhibits out? Or?
Mrs. Benson? They have been provided by Mrs. Benson.
You presented last week, and it's defendant exhibit quadruple V. Now, in this simulation, this was prepared by Dr. Malin Ornelas. Is that correct?
Yes, it was.
And this is the top simulation here is what you indicated was representative of a 25 milligram dose administered by Dr. Murray at around 1040 or 1050, and a 25 milligram dose administered by Michael Jackson around 1140 or 1150. Is that accurate?
Yes, it is.
And I know you indicated Dr. Ornelas is the one that created this, but were you working with her to create it? In other words, were you providing her data, information upon which she would base the simulation?
I did not provide her really any guidance whatsoever. She was watching the proceedings on television. I asked her about if she could help me calculate the amount of unchanged propofol in the urine in milligrams in these two different scenarios. And she came up with these graphic displays based on the two suggested possibilities, the one by the defense and the other by the prosecution.
And the the lower model on defense quadruple V, that is what, in your testimony, in your opinion, documents the relevant urine levels of unchanged propofol. Is that accurate?
That's with two 25 milligram boluses, one given slowly, the other one given rapidly. Correct.
And the exhibit, the lower exhibit on quadruple V states it's based on Simons et al. 0.3% measurement. Is that referencing a particular article or manuscript?
I believe that's the manuscript that Dr. Mellon Ornalis used for estimating the amount of free propofol you would expect in the urine. And it was, I think, a radio-labeled study, so it should be very accurate. And I think she also looked at other papers that confirmed this number, but I think that was the primary reference that she used in the model. And as I understand it, the model was essentially the same model that Dr. Schaefer referred to, one by Schneider et al.
And the article upon which you based your testimony as far as the 0.3%, 0.3%, is that this article I have in my hand? Let me put it on the screen briefly.
Yes, it is.
Okay, published in 1988. The first author there, Simons.
Correct.
And you felt that that was the most accurate accounting of unchanged propofol in the urine?
Actually, I didn't make that determination. Dr. Mellon Ornalis is the one who did the pharmacokinetic modeling. She's the one with expertise, not me. So she used what I think is, which appears to me, based on the fact that it was radio-labeled propofol, to be a very accurate way of estimating that. So I guess the answer is yes.
Did you read this article, Dr. White?
I did look over the article. I didn't really analyze it.
You came into court and testified regarding the unchanged propofol levels in the urine, told this jury your opinion. Did you read this article in detail upon which to base your opinion?
As I said, the pharmacokinetic analysis was done by an individual with expertise in the field.
Did you read the article, Dr. White?
I looked at the article. I didn't read it in detail, no.
Okay. And you started working, just to be clear, you started working with Dr. Ornalis. You first met her last week, right?
She was contacted by someone on the defense team as an expert in pharmacokinetics, and I had a conversation with her and met her last week, later in the week, Wednesday or Thursday.
How many hours did you put into collaborating with Dr. Ornalis to conduct your computer modeling that you've testified to this jury?
Firstly, excuse me, but I did not perform the computer modeling that you keep referring to. I don't know how many hours Dr. Ornalis spent working on this. I asked her a very simple question, not even to do modeling, just to give me an estimation of how much propofol you would expect in the urine if a patient got two 25 milligram boluses of propofol versus 1,000 milligrams, because the numbers that were provided at autopsy in terms of concentration of propofol, free propofol in the urine, did not seem to be consistent with a 1,000 milligram infusion given 3 hours before Mr. Jackson died. So
how many hours, I'm sorry, doctor, how many hours did you put into collaboration with Ms. Ornalis prior to your testifying, so you were competently informed as to the data and the literature that you were relying upon?
I had a conversation with her. She came over to the house I was staying at the Flanagan's house and
Mr.
presented...
Flanagan's house?
Mr. Flanagan's house, yes. And we had a conversation about the kinetics. I asked her if she could provide the details about the modeling that was used, and she was kind enough to provide that hard copy. I didn't know that a disk and the software was required, so I didn't request that from her. But I would say it was not a tremendous number of hours because we didn't have a tremendous number of hours.
And when was that meeting?
I believe it was near the end of last week. Days kind of go together since I've been here several days in a row.
And do you have the laser pointer there, Dr. White?
Yes, I do.
Can you point on the upper model on defense quadruple V? Where is it that Dr. Murray infused 25 milligrams?
At this point.
Okay. And
Far left peak?
Yes, sir.
And again, that's approximately 1040 or thereabouts on the model?
This is 1030, this is 11, so yeah, I would say that's the best estimate we have, yes.
And where is it on there that you've indicated that Michael Jackson infused a same amount of 25 milligrams?
At this point.
Okay, to the right portion of that model.
Yes, between 11:30 and 12 o'clock.
And in your model, based on where it's located on that chart, it's about 11:40 a.m. Is that fair?
Dr. Ornelas actually drew up the model, as I said. I didn't tell her the precise time.
But you've based your testimony on this model, correct?
I based my testimony regarding the likelihood of 2 25-milligram boluses versus a 1,000 milligram 3-hour infusion.
Based on this modeling that you testified to last week, correct?
In part on the modeling, in part on the fact that there was no infusion setup found at the scene.
Do you take any responsibility for these models that you previously testified to?
By taking
I'll object to that question. It's being vague.
Sustain. The partial answer stricken. Re-ask.
Prior to, on this model, on the top portion of this model, prior to what you indicate is a 25 milligram injection by Michael Jackson, what is the blood level or the blood concentration of propofol just prior to that?
I'm sorry, are you referring to this point?
Yes, the one that you've testified indicates Michael Jackson self-administered propofol. What's the blood level just prior to that?
Well, the blood level that...
Prior to the injection, what was the blood level as represented in the model?
Well, it looks to be very low.
Zero?
The propofol level wasn't measured. It was only measured at one point in time, namely at autopsy.
Where was it on this model, Dr. White? Was it about zero? Would you agree with that? Isn't that long line running along the bottom of the model?
Yes, but it's a very